Welcome back, everybody. This is the Func Med Nation podcast. And today my guest is Dr. Chris Turnpaugh. Chris and I, we've known each other, what, I would say close to 15 years now?
Yeah, pretty close. Yeah.
Something like that. Yeah. So before we started recording, Chris and I were just catching up and making comment that there's so many things that we could talk about. One of the things that I love about you, Chris, is that you've got such a rich and a deep experience, not just on the clinical side, but on the business side. And I know that you've worn many hats over the years. And so, as I mentioned just before we started recording, I want to keep this kind of big picture. I think that if you and I just let ourselves go, the conversation would quickly devolve into clinical stuff.
That's where we live. Yeah.
That's where we live, right? It's where we live and the passion. But one of the things I want to talk about, and I've got a handful of things on my list of things to talk about today, is just to talk a little bit about, what's going on at your clinic right now, the fact that it is one of the largest functional medicine clinics in the country, and I would say probably in the world, right? I would say that U.S. is a Func Med leader internationally. And so that's a big feather in your cap, but you didn't start that way.
No, not at all. Not at all. And nor did I have the grand scheme. This wasn't my plan to build the biggest functional medicine clinic in the world. It kind of started organically, and it's just grown and taken off. And I can talk about how we got there and all the steps and the missteps that got me where I am. But it started off.
Why don't we do that? Like, let's go back to the early days, because I think you got your start. You and I have talked about stories and how we got started in this business. You just started before I did, and if I remember correctly, you were first exposed to some work that Jeff Bland had done, and he was. And correct me if I'm wrong. Was he the inspiration that got you into all this?
Well, it's an interesting story. I've told it many times. I'll share it officially with you now. So 1995 or 96, I was a chiropractor with my diplomate in neurology. So, then when you're young and right out of school, you know everything. I mean, you just know everything. So I had a patient come in, and interesting, I just shared this with Jeff Bland. We did a podcast together, and we were talking before the podcast, and it was interesting. He never knew the story. So I had a patient come in with ALS. And he was searching, and of course, you know everything because you have a neurodiplomate, and you have everything figured out, and you're the smartest person in the world. The day you graduate and you realize over the years you're not so smart. And he said, "Can you tell me about coenzyme Q10?" And I never heard of it. I never heard of coenzyme Q10. And he says to me, points his finger in my chest. He said, "You need to learn or you need to quit." Because
crap.
We became fast friends. I spent every Sunday with him for the rest of his life. And he said, "You need to learn or you need to quit, because my life's on the line and I don't need people that aren't going to learn." And that weekend, Jeff Bland was speaking in New York City. Mm-hmm. So I said, "I don't even know what he's talking about."
Yeah.
I went to my first Jeff Bland seminar. I think it was 96. And, he's talking about things. If you never heard of CoQ10, you never heard of NF-kappa B, you never heard of anything he was talking about. And I was like, wow, I really need to step up my game. And so that was the first foray into me learning that there was a whole world I didn't know anything about. And I was not serving patients because I didn't know anything about it. So Mark Yerk was his name. He lived for another 7 years, and I've tracked with him, and I spent many, many, many days with him. And he forced me to learn. He forced me out of my comfort zone and forced me to educate myself. And it's not a theory. It's a human being sitting in front of you whose life is on the line. So it was a fast fire right under my butt.
Yeah. Do you think that, I mean, that's a pretty strong statement, and what a way to get introduced to the whole world of functional medicine. But strong statement for someone to say that this is my life, basically learn or quit.
Right.
I mean, because I know you're kind of a type A personality. What rose up in you in that moment? Like, what was your emotional, psychological reaction?
Yeah, the first thing I'll tell you is defense. That's a natural, I was defensive. Like, what are you talking about? I am one of
Don't you
the, I
see?
mean, I have my diploma
Look
on
at
the
all my
wall.
credentials. That's right.
I'm one of the few hundred people in the world that have a neuro degree. Of course, learn or quit. What are you talking about? And but then it quickly, you put yourself in the other person's shoes, and you say, well, he knows something I don't know, and I'm sitting here in a privileged position because I don't have a diagnosis of ALS with a terminal diagnosis. So, wow. And then quickly turn to humbleness. The initial emotion is defensive, like, who are, and I think that's a natural progression. Like, you don't know about this. Like, who are you to tell me what I don't know? And then you quickly become humble and say, well, there's probably some educational points here that I could pick up on. And then the eyes got open quickly. And then it's a beef of mine. It's a problem with me, but everybody thinks they have it figured out. And I will tell you that I've done most educational programs out there, and nobody has it all figured out. And we've lectured many, many times, and I start every new patient off by saying, I'm probably going to make a mistake in this case, just so you know. I don't have it all figured out. You've seen 12, 15 other providers. They're all pretty smart. I'm going to add a nuance to this or a different pivot point to this, but to think that I have it all figured out on day one is kind of facetious. And also, I've said this for 25 years. If I had to practice the way that I did 5 years ago, I'd quit. So it's a continual learning thing. And I think it's an important message to get out. Just because, I think we've all said this when we talk, you don't have to be as good as the person in the front of the room or the person next to you. You just have to be better than you were yesterday. You just have to keep progressing and working it and get your craft.
Hey, I love that. I had a client say to me, and more than one has said this to me over the years, like, I wish I met you 10 years ago. And my answer is no, you don't.
No, you don't. Yeah.
Because I wasn't the same practitioner 10 years ago that I am today. And it took, I kind of had the same, I guess it's like you said, it's a growth process. You get to the point where you realize that you don't know what you don't know. And that's a huge undefined domain of knowledge. And it's way bigger than the stuff you do know, like way bigger. There's so much that we have yet to learn. And I said this, in fact, I interviewed Datis for the podcast a couple of weeks ago, and we were chatting. And, quite often when I teach Func Med seminars, especially if there's a whole bunch of new practitioners, even if there's a whole bunch of old salty dogs, like you and I, it's like the smarter I get, the dumber I feel, right? Because you start to see how complex human physiology is. And if you throw into the fact that no individual person's physiological terrain is obligated to follow anything I think or say, then all of a sudden you have nothing but endless possibilities of what could happen and what might happen just based on any choice or any recommendation that you make. That's it's a humbling thing, isn't it?
It's very humbling. So two things I'll say. When I felt kind of accomplished a little bit is when I would lecture and I felt comfortable fielding questions, because I felt comfortable enough that I knew I had enough breadth of knowledge that I could talk intelligently about a lot of things, but also humble enough to say, I don't have any idea the answer to that question. I don't know the answer to that question. And the second point is that we were sharing beforehand, my wife just had de Crevaine's tenosynovitis surgery. And the surgeon, who's a brilliant hand surgeon, brought his daughter in, and who's in med school. And during the surgery, my wife is awake, and the surgeon says, do you see that? That's why you can't just look at your anatomy books, because everybody's different. You see how she has an extra tendon there, an extra sheath around that? So it just was humbling to me to talk to his daughter and say, this is what the anatomy books teach you. That's just kindergarten. You have to get past that, and you have to see what real life. And so you're saying everybody's an N of one, and they kind of have similarities, but the physiology is completely different.
Yeah. And so, you said the N of one, and I've always thought that, there's a big trend and you and I both do this, to look at published medical literature, right? To understand pathophysiology, to understand the physiological impact of different natural compounds. There's, I think, a tendency to, in some cases, overvalue medical research. You start thinking about large scale studies, very large N numbers, which, might eventually trickle down to the point where, the impact factor of some kind of finding is pretty high. But then you start to factor in this biochemical individuality, and I start wondering how often we make assumptions about what's published in the medical literature about what will happen, what does happen, and then we get into clinical practice with real people making real choices in the real world, and we realize, well, sometimes there's not that direct translation from research into practical application. I mean, do you tend to have those same thoughts as well?
Yeah, my thought is, so when we get together as a clinical team, and we have quite a few clinicians on staff, we'll get together and it's just a starting thought process. So the research gives you a starting thought process, and then you realize quickly that doesn't apply. If you're on the distribution curve and you're 2 standard deviations away from the norm, then that research paper doesn't apply to that person. It doesn't mean that it's wrong. It means it can give you a starting point, but most of the time you're going to have to pivot off of that. And when you say, well, it should work because the research says it should work, you have to be humble enough to say, but it's not. It's just
it's not working that way.
So
it's not working that way.
Yeah. What's your pivot point? What's your fallback on that? And so I spend more hours than I should reading research to give me a global understanding as a starting point. And I realized quickly a lot of that goes out the window because it doesn't apply to the human being sitting in front of me.
Yeah. And I think that this is probably just part of statistical analysis and just the whole world of research, is that averages based on large scale populations don't always include the person who's sitting in front of you.
It's a story, anecdotally, the average shoe size in a male is a size 10. But if you put a size 10 shoe on you or I, it's not going to be comfortable.
It's not going to work.
So but it should, because the size 10 is what's supposed to fit your foot. Well, I'm a 12 and a half and I know you're bigger than a 10. So you put it in there like, my foot hurts. Well, it's a problem with you. No, it's a problem with the shoe size.
It should fit. Right. Yeah. Very apt. So listen, we got a little bit off on a little bit of a bunny trail, but it's all good stuff. Talk to me about, what was the growth curve in terms of going from, were you just a solo practitioner when you first got into functional medicine? Did you have a period of time where you tried to run chiropractic and musculoskeletal work, neurology work with functional medicine, or did you make a shift pretty quickly?
So when I started and I met Mark, the gentleman I told you about with ILADS, I was actually at another facility, and it was by definition multidisciplinary. So there was an MD there, but they didn't do any Func Med. They did more rehab, and they had the pieces in place so that the billing could work better because you had an MD on staff to do different things. And then I wasn't satisfied. I won't get into too much of the politics of that, but I wasn't satisfied with the way it was going. So I went out on my own January 1st of 1999. And I did probably, I'd been practicing since 95, but that's when I went out on my own. And I started my own, and I did mostly musculoskeletal type of stuff with a little bit of Func Med. I was ordering some labs at the time, some simple things, and mostly for the patients that, even chiropractically, boy, they should be getting better and they're not. So clearly I'm missing something. And I'll go to a very simple, hey, you're not getting better. You seem to have to come back. These muscles are fatiguing. Maybe it's your thyroid, right? Just really simple kindergarten stuff. And I would find that this was going on, but if I didn't add that piece, they weren't going to get better, and I wasn't doing them any service. And so over that time, it kind of went to, I grew quickly to about 50-50. So it was about 50% of my practice was functional medicine, 50% of my practice was musculoskeletal. And then in 2008, I had a pretty nasty bicycle accident. I broke both my wrists, my collarbone, my radial head, 6 surgeries, and I couldn't use my hands for 2 years.
That's a death sentence for a chiropractor right there.
Yeah, and I was pretty much told, actually, I went to largely considered the world's best hand surgeon. He said, you're done adjusting altogether. You're done for life. You're not going to be able to use your hands again. So I had 6 surgeries and couldn't use my hands. And so I was able to do more of the functional medicine piece. And I was very blessed. I had some friends who are chiropractors came in, took kind of care of the musculoskeletal piece, and I did functional medicine. And within 3 months, that was full. Because I already had a little bit of a reputation as functional medicine, kind of go to this weird guy that did weird stuff. And so that kind of blew up. And that was kind of me being forced into the foray of, hey, you have to do more functional medicine. This is where the need is. This is where the population is saying they're struggling. And then that's how it started based on an accident where I did full-time functional medicine.
Yeah. I mean, I've talked to so many, and I have my own version of the, when your back's up against the wall, you have to reinvent yourself.
Right.
Right. I won't go into it because this is about you rather than about me, but I've talked to other people in the healthcare profession, not necessarily, coming out of chiropractic into functional medicine, but, at some point, life throws you a curveball that you can't just pivot and knock out of the park. You have to change everything. So, you said earlier that you never set out in life, number one, to do functional medicine, and certainly didn't set out, number two, to build the largest. How did you get there? Was it just like all of a sudden one day you woke up and you're like, wow, we're the largest clinic in America? Or at some point, was there a plan? Because you and I have had a couple of conversations somewhere along the way, just like in the beginning, that gentleman showed you your need to know about biochemistry and nutrition. And then somewhere along the way, you learned the need to know about other things. And then you start to realize, well, I can't be all things to all people. And there are other people who are as good as I am in doing what I do and what they do. Maybe we can bring them on as part of a team and then start building the team. So what was that process like? And are you done yet?
No. Well, so you and I share a similar heart. So, so I had billed quickly about a 2.5-year waiting list. And that people are like, oh, that's great. And I say, no, that's terrible. Because if you're really a servant, you're not helping those people that are waiting that long. So we needed to expand. And my wife had said, we were in a real small office. We bought a big office, took a big leap of faith, bought a big office. We bought it from the hospital, and their exact words to us were, you're going to go bankrupt in a year. We'll be happy to buy the building back. And the office we're in, we expanded on it now, but it was 6,000 square feet. All my kids had their own offices they could play in. It was empty.
Yeah.
And quickly, though, we became attractive to not just patients, but providers. So we started having providers ask if they could join our practice and learn that there's an awful lot of people that do functional medicine, but would like to have some kind of a leader or a coach, along the way. And nobody likes to be an island. So we became kind of a hotbed for people joining the practice. So we had other providers seeking to join our practice, and they would come in, and much like a lot of us, I've had like 200 people shadow me, come in and sit for the day, and IFM, A4M, ILADS, all of them. And so they would come in, but when they joined the practice, they would sit with me for 3 months, and then they would go out down the hallway. And so it kind of grew organically. We had no intent. We had a building, we had empty rooms. My kids don't have any offices anymore. And we put an addition on. So it kind of started not with the desire, but for the need. Like to say you have a waiting list, it sounds good if you're trying to get your name in big lights, but you're not really serving the patient who's waiting 2.5 years to be taken care of. So
yeah, no, absolutely. Yeah. And it's, you and I both know it's at some point, the average practitioner just gets caught into that, the whole pride and the self aggrandizement about, look how busy I am, and look how long my waiting list is, and, whatever. It's, and I don't think we're the only ones. I don't think any profession is immune to that tendency.
Right.
But, when I moved to Florida and started working we started out as just a 2-man chiropractic office, but the guy hired me to take over his caseload because he wanted to hire an MD so we could integrate. And we did that. And we grew to, I think it was 8. When I left 10 years later, we had 8 practitioners, multidisciplinary, and 30 staff, something like that in total. But, we went from being a small clinic that was focused on really caring for people to every month it became about how do we pay our bills? It's more on the business side of things. And that's kind of a dicey thing to balance. And I think you're very smart. And I think we were talking about this before we started recording. You were talking about saying to people, like, that's not my job. Like, you know what your role is, and you're not trying to wear every hat. And I think that's probably one of the better ways to protect yourself from falling into that trap of constantly patting yourself on the back, feeling good about how you look to everybody else, while all your people you're taking care of are falling apart and they're not getting the care that they need.
Correct.
So I kind of have two questions just based on what you've said in the last couple of minutes. Number one is, what other ways do you protect yourself as you continue to grow? And you have what, 20 providers now?
We have 20 providers, and then we have it depends what you call provider. So we have a bunch of RNs and LPNs and
let's include those as providers.
So over 20 providers.
Yeah. So you've got a couple of dozen providers. What other ways do you protect yourself from losing sight of what really your core mission is, which is to help and serve people who are unwell? Let's answer that, and then we'll come back to the other question.
So, my goal is to be a clinician. That's what I've always wanted to be. So I cut my teeth getting my hands dirty. My favorite thing to do is teach. That's my favorite thing to do is lecture. But how do you lecture? How do I lecture? I'm not projecting. How do I lecture if I don't get my hands dirty every day seeing patients? So when I teach real world. This is what walked in my office. This isn't what was in the anatomy book.
Yeah,
this is real world. Right. This is. So I love teaching, but I like to get my hands dirty. And then as you build, so we have 61 support staff to support so it's an organization now. And so we have had to grow. We have a COO, a CEO, a CFO, a director of human resources. We have a whole supplements department with a senior manager over there. And we have processes in place, like most business structures now, which I give my wife most of the credit for. But it is, you have to put those other pieces in place, and it can't be you. So when we hired a CFO because our accountant said, you need this, and we don't know what we don't know. So we're like, okay. So we went out and we hired a CFO who did a ton of work for us that I'm not qualified to do, and very few people are qualified to do. When we brought on a director of human resources, one would think, why would I spend, 70, whatever it is? How are you going to spend all this money? It's so important, because as you get to a larger staffing of 61 support staff, there's things that you never thought about, and grievances and workplace situations that you never thought of. And the other thing is, we have to legitimize what we do in every aspect of it. And so, to be a legitimate business, you have to take on those difficult questions and make those sacrifices. And so those people handle that side of the business for me. And as I was saying before we recorded, I have final veto power, but I'd be a fool to use it very often, because now I'm vetoing people that have better insight and better qualifications than I do. It's more if this is a direction we don't want to go. So it's kind of all grown, again, organically, to, as you grow, what support do you need to put in place? And I do see a lot of offices that try to maximize their income, so they don't sacrifice that to put that support in place. And then the patient suffers. So, we have full-time MAs to field questions for triage. They're calling in, and they don't want to hear, oh, the doc's with a patient, he'll get back to you at his convenience. They want an answer. And, well, I could do that, but now I'm going to have to pay somebody to be there on the other line. That's what the patient really wants and desires and needs, and that's best practices, best care. So it's kind of grown that way. So I even forgot the original question, but the way we've gotten to where we are is, I've recognized that if you keep the patient in mind, if you're patient-centric, then what is best for the patient, not what's best for your pocketbook or your wallet, what's best for the patient, and how do you put those places? And it's painful at times. It's painful when you say, we're going to spend and again, it's all different for different offices, but you're going to say, hey, we're going to hire a couple people out, a couple $100,000 in salaries. And if you don't do that, you can put it in your pocket at the end of the year. But if you do that, you're not going to be around in 5 years, or you're going to be tarnished. You're not going to be as good as you. So
No,
they're not
that's a
patient
very good
centric.
point. Very good point. How freaked out would the young Chris Turnpaugh be if you went back in time and said, here's a glimpse of what's coming down the pipe?
Oh, I would run. I would run. It's to get from A to Z or whatever letter I'm at the alphabet now, to not have gone through the growing curve that I've gone through, I would have been terrified to have an organization and the responsibility. We just had the holidays and Christmas here, and you're responsible to your patients, but you're also responsible to, I'll say, the 61 mouths you're feeding that relying on you for an income too. So there's responsibility you have to these people. And, we grew out of a small family business and we still run it like a family business, even though it's bigger. So our hearts are always in the right place. And we take that very, very personal, that everybody is an individual that has needs and we try to meet them. And so it's a lot on me, and I don't know that I wished for it. I think it was placed on me. I don't know that I really sought it out. So
I think something that's perhaps inspirational for people who are maybe they've been in practice for a while, they're small and they want to get big, or maybe they're new and they don't know what's possible. You've done all this in a relatively small community. Like, you're not in this massive thriving metropolis, right? I remember having conversations with you in the early days, like you're in Amish country and saying like people are like paying you in chickens and butter.
Yeah. Right? Literally. Yeah. So we're in rural, we've lectured in most of the big cities, and every time I lecture, like, what are you doing in central Pennsylvania? I mean, why wouldn't you be in LA or DC or New York, where it's popular and people have the income? And my answer was, well, this is where I am, and there's sick people in central Pennsylvania too. So
yes.
And so it can be done. I honestly believe in my heart it can be done anywhere. It doesn't have to be done. You don't have to just do a demographic research study to find out where the income is. There are people that are seeking this type of care everywhere. And if it can be done in central Pennsylvania, I think it can be done anywhere. And I think a lot of times, well, that's because you're here. A lot of people are making excuses as to why they're not successful in this demographic, and not looking inward and say, what can I do differently in my business model to make this successful in any demographic? So we literally, our second office was in Lancaster, and it grew organically. And I did a lecture for an Amish festival, 4,000 Amish people, and they said to me, what do you need to build an office here? And humbly, I said, I could work in a closet. So for the next 6 months, I worked in a closet in an Amish place. So, and it grew to the point where that's now a satellite office with 5 practitioners in it, and support staff. So it can be done anywhere, in any demographic, in any environment. So
you said earlier that when you bring someone on, like a practitioner on as staff, that they, if I heard you correctly, they follow you for 3 months.
Correct.
Why so long?
So,
I mean, I think I know the answer, but
it depends on the practitioner you're bringing on. So some of them are seasoned and some of them are rookies, and they both carry strengths and weaknesses. But somebody who's been around for 40 years working in a hospital, there's a level of confidence that may supersede their level of ignorance. Right. So you say, hey, you know a ton. And I say, you never forget what you've learned, but you have to know what you don't know. And you see how quickly they're coming in contact with patients with different nuances that maybe they haven't seen before. And the same is true for a newer practitioner who's newer. They need to learn from zero up, and until you're, I don't want to sound arrogant, but trusting a patient's life with them, you just want to make sure that they have some safety nets in place. And we are very blessed, because one of our safety nets is we walk down the hallway and ask a question. Hey, what do you think of this? Hey, what do you think of that? But when you go out into a solo practice, or you're by yourself, or maybe you're with 1 or 2 people, you don't have that, hey, there's 20 people to ask a question to. Have you seen this before? What do you think of that? So I think just to give them that breadth of knowledge with some roots and some depth, I thought it was important. I think a big thing too is we want to keep a culture here at Turnpaugh Health. And I can come back and say, have you ever heard me talk to a patient in that manner? Do you see how I treat a patient? Do you see how I use a phrase, I'm sure I stole from somebody. I have a soft front, a firm back, and an open heart, right? So you see how I can lead with softness and graciousness and an open heart. And then there's a time where you have a firm back and say, no, we're not crossing that line. We want to keep that culture here. So it's not just you're the greatest clinician on a textbook. You have to be able to communicate with people and hear people and listen to people. And so I wanted to create that same culture. And I learned quickly, not picking on any organization, but early on, a lot of the IFM practitioners would come and sit with me, and they would immediately dive into these complicated esoteric tests and spend a bunch of money, and they haven't run a CBC or a CMP or a thyroid panel. And so before you jump into that, and not that they're bad tests or unnecessary tests, or they don't give you knowledge, but you can learn a lot before you spend all that money with a patient.
Yeah. And I think, that I have like a patient facing podcast, right? Inflammation Nation, that I started a year and 2 days ago. It was the 26th that I put out my first episode last year. And I just finished up a short mini series talking about diagnostics and, breaking tests down into tier 1, tier 2, tier 3. Like tier 1 is the testing that you would do on pretty much everybody, because we are all humans and we have physiological systems that we need to understand and assess, right? And so that's kind of broadly applicable. Tier 2 would be tests that you run on maybe a lot of people, but not everyone. It would be case specific. And then you have tier 3 tests that you run much less frequently, just because it really is on a case by case basis. So at Turnpaugh Health, what do you think? What's tier 1 testing for a good functional medicine clinician?
Well, let me even digress a little bit more than that. So we are in central Pennsylvania. We're not in LA. So we have patients coming. We had a patient who came in because she saved up for 6 months to pay for her initial visit, because we don't take insurance. But then she forgot she couldn't afford the cab to get here.
Oh gosh.
Right. So we obviously we did a lot for her, but so for her it might be a little bit more challenging as to what even tier 1 tests. She doesn't have insurance. So what can I do on a shoestring? Now, when I do that, I'm going to have the conversation. There's going to be more holes in my diagnostics than other patients typically, but that's where your clinical acumen can come in, and the benefit of 25 years of experience. But so if you say, listen, a regular patient, to not get too deep, they're going to get a CBC, a CMP, a thyroid panel. I'm going to run, even if I run some, I don't want to get too detailed, but like an ApoB and an ApoA1A and an LP(a), just little things and they're cheap tests to assess that. I'm going to run inflammatory markers like glyc-A and CRP. And then that's a bare minimum. And I mean, that if I only ran that, my phlebotomist would come back and say, have you had a concussion? Right. So
what's wrong with you today?
But so those are some basic ones that I just don't think can be missed. They're the early starting points. And then what else is going on with the patient is important. I can tell somebody to change their diet pretty much without running a bunch of tests to begin with. So I don't have to spend a lot of money doing that.
Yeah.
I'll typically run an omega check to make sure, see what their omega-3 fatty acids are, just to kind of get a baseline. I never miss a vitamin D, on everybody. So I'm going to run some basic stuff, and then I'll build from that based on the conversation I have with the patient, their comfort level, their financial commitment to it, and go from there. But those are ones that I just don't think can be missed. I don't think they can be missed.
Yeah, and I totally agree with that. And talking about, in some circumstances, you can accomplish a lot with diet, for example. One of the things that I've tried to focus on in these last few years, not necessarily de-emphasizing diagnostics, because I love data, right? I love information and I love clarity, especially with certain types of cases. And I know you and I share that same trend, as we tend to see more complicated cases. And that's not true for everyone, and I get that. But, I've really tried to do more with less. And I've put more emphasis on I call it finding someone's ideal diet. I've put more emphasis on that process than I ever have in 15 years or so of doing functional medicine. Back in the day when I first started, I thought it was all about tests and supplements. And, if there was a diet recommendation, it was like, oh, I hear paleo is good.
Yeah.
Go buy the book or something like that. Right. And so how I approach things clinically has really changed. And, I was thinking when we were talking about that 3-month period that you have people shadow you before you let them go out on their own and work with the clients that you serve. I understood part of that was so that they could see how you interact with people and the culture that you were talking about. I would also imagine it would be undoing some of the, not wrong thinking, but trying to get them to see that there's different ways of doing things, and you can meet people where they are and still do a good job. You don't always have to have all of this. It's nice when you do. It's nice when you get that. But what do you do for the person who can't afford cab ride and all they can pay for is your first consult? Like, what do you do with that person? You say, no, that's a line I'm not going to cross because we can't do enough. I mean, I love that about how you guys have modeled your clinical and your business practice.
Yeah, that's a very important point. So they would come in, and a lot of times I would say, what would you do after the patient would leave? I would say, what would you do for this patient? And they had a beautiful workup, like they're writing a case study for A4M or IFM or like, and I'm like, you just spent $3,000 in testing. They're not any better because they haven't done anything yet, because you haven't implemented anything. They probably, I don't know if they can afford future care. You probably overwhelm them. And we missed some of the easy things. And so that was the biggest learning curve for the providers that came in general, not all of them, but in general, is you don't have to do everything you learned at the seminar. What you have to do is sharpen your clinical saw. And that comes with time and experience, and also the ability to have the humbleness to ask a question. Hey, what do you think? Should I be running this test? Should I be doing that? And that's nice as a community. And I think there's more functional medicine communities forming where you can ask a question. But to your point, I think everybody felt in functional medicine, which is kind of a Wild West term because it means something different to everybody.
Agreed.
So, but you don't have to do all that advanced testing. And to fall back, we have 3 full-time health coaches to help people with diet. And a new patient is required to sit down with them for an hour, whether they think they need it or not. It's included. It's not an additional fee. It's included as your new patient fee. You come in, you sit down with them, because if you can't change your macro environment, you're not going to change your health. And it doesn't matter what supplement or what test or what medication. It really matters, what are you doing to influence your environment?
Yeah, you can't out supplement a bad diet if that needs to change, right?
Right.
And that was a mistake that I certainly made many times early on in my career.
Well, the diet front is interesting because the diet front changes. What was right in the 80s was wrong in the 90s, and what was right in the 90s is wrong. And now it's not decades, it's years. And it's, oh, this is right, that's right. And so, I like to refer to myself as the village idiot. Sam Yannick and I, we talk all the time, and I call myself the village idiot. He hates it. I said, but I just keep it simple. Like, I just try to keep it simple. So if we can clean some things up in your diet and make it better. So I'm not married to paleo or keto or vegan or pescatarian or carnivore, but there's ways to veer from the standard American diet. And as you and I both know, if you change from a standard American diet to any kind of diet, you're going to improve pretty much. So if it may be, and I also say it might be right for a season. So this might be the right season for you to do that kind of a diet. But just because it works for a season doesn't mean you don't work out now like you did in your 20s. It's a different, it's different seasons of life. Yeah. So, but I think the diet is huge. And I think concepts rather than dogma of you must follow this type of a diet, but concepts of improving your environment are key, and they're free. You're going to eat, so you can make better choices on what you're going to eat. It doesn't cost you anything. And more importantly, it will help the case fail if you don't change your environment.
Yeah. So I have 2 categories of questions. I remember sitting with you and Sam and probably a couple other people, probably in the first couple of years that it was probably out when we were in California with the speakers conference. And we're all talking about our business models. I think we're all kind of in general on the same page when it comes to clinical models, but we were talking about how you work with people, whether you do fee for service or do you do prepaid packages, and do you have a set number of visits and all that kind of stuff. And I remember some of the things that you had said back then, and I think at that time we were all just trying to work it out, trying to figure out what works for us and what kind of jives with how we think and all that kind of stuff. And so walk me through, and you can share as much or as little as you want on the business side, but walk me through the process of taking on a new client and then working with them over a period of time. Like, what does that look like? If you had a cancellation tomorrow and I grabbed that spot, what would happen?
So typically we call it the first visit, but it's broken up into 3 visits. So your first visit, you'll come in, I'll do a consult with you, detailed history, exam, pertinent exam. Then from there, I'll order labs on you. If it typically order labs,
yeah.
I would say 99% of the time I'm ordering some kind of lab on you.
Sure.
Then your follow-up will come a couple weeks later when we get the results back. I'll map out a plan, and that will also include a consult with our health coach and a certified nutritionist. So, and then that will be our plan. I'll follow up with you in 3 months after that. Now, we have support staff, nurses, your health coach. You can check in with people, and many times based on that, I say, listen, I'm going to have our health coach reach out to you every 2 weeks just to check in, see how things are going. But you're not coming in to see me typically.
Yeah.
There are exceptions, but this is the rule.
Sure.
And there are exceptions to it. I'm going to see you in 3 months. So one of the reasons for that is it actually started early on when I didn't have time in my schedule to get them back in. So I'm like, well, all right. And a lot of change takes time. It doesn't happen overnight. So if I'm going to see them in a week, I'm not sure what I'm going to talk to them about. And then ethically, for me, if I see you in a week and I charge you, what am I charging you for? I'm not getting any new diagnostics. I don't expect physiology to change in a week. What's going on? If you have a complaint or an issue, I want to hear from you. So typically they'll come in, first visit, exam and clinical background and everything, and then I'll order labs. 3 weeks later, I have the follow-up where I put a plan together, and then I'll follow up with them in 3 months and see what and I'll order labs before the next follow-up, and I'll see what kind of changes have been made. And then in between, any problems, speed bumps in the road, potholes, they're going to call out, and we're going to massage that into their schedule as needed.
And during that 3 month gap between your second, like your report of findings and when you do your final follow-up, are you getting regular updates from your support staff? Like, hey, saw Mrs. Jones today and she's struggling with this. And are they in communication with you about what's working, what's not at that point? So you're kind of in the background. I'm in the background.
Yeah, exactly. I'm in the background. Our EMR has this messaging system back and forth. So there's all these messages back and forth. So if I say, hey, Mrs. Smith, I want you to reach out to her every couple of weeks, see how she's doing, they'll message back to me. I try not to get involved because I don't want to develop doctor dependency. We're like, I got to call them every time I have a hiccup or, I burp or fart, I got to call them. And so we want to kind of let them go through some of the hard, tough changes that are going on early on with some support. And then if need to escalate, I'll escalate if need be. But I like to kind of keep myself in the background to give them the confidence and the understanding that they can do this. They can do this with or without me at some point. So
right. So then you get to your third visit 3 months down the road. Then I would assume that you do an evaluation, and then at that point, do you make a recommendation for the next 3 months? Like, am I hearing that you kind of have a 3 month mini package model, that it's just kind of rolling up to the point where, okay, we've done what we set out to do and we're both happy with where you are?
Correct. So in a perfect situation, some of the other clinicians, they'll have a little bit more availability in their schedule. They might do a check-in with them in 6 weeks, bring them in, talk to them, see what's going on. Maybe if there's a lab that they need to run, something small. But for me, you'll come in, first visit, 3 weeks later, follow up. We'll put a plan together. I'll see you in 3 months. evaluate what's going on, what's working, what's not working. Typically, if things are going as well as can be anticipated, it'll be another 3-month follow-up.
Yeah.
And at some point, the goal is to get them to a point where I will follow up with them either once a year, once every other year, or at that point I say, but you're where you want to be. If it were me, I'd follow up in a year, but if you're good, you just call me when you need to, type of a
Sure.
thing. And most of the time they want to know what their numbers are in a year, or I have a fair amount that do every other year. But I fully divulge, and I will here too. I run my labs every month. I get 21 tubes of blood every single month.
You mean you personally?
Me personally.
You
so
personally, yeah.
I have more labs than any patient under the sun. And I don't even know what to do with all of them, but I want data points to be able to look back. I mean, I am the ultimate data point for this clinic. So we've looked back at my data points from everything.
In fact, I think the last time that I saw you face to face was in Manhattan. I was teaching. You came by to say hello, which I still truly appreciate. And I think you had just started playing with a continuous glucose monitor. I think it was around that time. Right.
So we do now. A lot of patients will get the CGM, and we use it. Again, I have a bias. People come out and say, this is what you need to do. This is the answer for everything. I think it's helpful. I do think it's helpful. It's very valuable. It's not that black and white as anything in our profession is. This is the answer and this is what you need to do. I think it's been helpful. I don't think it's been that miracle involvement that a lot of people thought it would be. It's very eye-opening to patients. We have them wear it for 2 weeks at a minimum, because it's, they'll wear it for 2 weeks, kind of get an idea. Sometimes they'll wear it for 2 weeks, and then we'll have them wear it again 3 months later for 2 weeks, just to compare what kind of changes they've made and see what's going on. Well, so we try and do those wearables or things that, whether it's how they're sleeping or how they're moving, or, just to give them direct feedback. But yeah, we still do that. Still do a lot of it.
Yeah. And it seems to me that you can learn what you need to know from those things very, very quickly. You don't need to wear them for 3 months at a time.
And I see other practitioners promoting, like, they wear their CGM every day for a year. And I said, well, you're looking for the needle in the haystack, and that's not where your process of dysfunction isn't coming from that July 17th, glucose that went out of range. That's not where it's coming from.
Yeah. And that brings me to the question, which was my second question, about, because we just talked about business models, so to speak, and there's obviously bleed over into how you manage cases. But from a clinical model, like you and I have both taught for DTIS and Apex for a long time. And in general, we teach this clinical model that's based on a set of hierarchical systems. Like certain things are more fundamental, more important than others. Do you use that in your practice? I mean, do you have a set of priorities, and do you even have a clinical model that, as the head honcho of Turnpaugh Wellness, do you say this is how we operate, and that's part of what you're teaching, let's call them new recruits, when they come and they sit with you for 3 months? I mean, are you showing them how to work up a case, or are you intentional about that, or is it just all by osmosis?
Probably a little both, a little bit of both. So I use the analogy, there's a very large clinical plate in our office. And I like to think I'm at the center of the plate, not because it's right, just that's where I sit, in the center of the plate. You can be anywhere on the plate. You can be on the left side, the right side. You can't be off the plate. You have to be within a certain guideline. You have to hit the target at some point, but you can have your own biases as long as they're within that plate. Mm-hmm. But you have to start and learn my model first, and then you can build your own nuances to that. So, I don't like to think, a lot of clinics out there, they're the diabetes clinic, or the thyroid clinic, or the Lyme clinic, or the mold clinic. And I like to think we're the I don't feel good itis clinic. That's a term I made up. It's not official, but I don't feel good. You can come with anything. It's our job to figure out what it is. And many people come with this preconceived notion, well, it's my Lyme, or it's my mold, or it's my food, and maybe not. So we want to get that breadth of knowledge. And so we'll work them up we have to make sure we're controlling their gut permeability, their inflammatory problems. Are they drifting towards autoimmune? Are their hormones balanced? Do they have an underlying pathology or an infection? Are they sleeping, and is their brain healthy? And kind of, and I'm doing this off the top of my cuff because other people probably have written down in my office, but this is me just thinking out loud, like I go through that. So how's your mood, mental status? How's your sleep? How's your diet? I ask the difficult questions, even like, how's your sex drive? How's your libido? How's it changed? What's your, are you less tolerant? So we want to kind of hit the basics of, is it hormonal? Is it brain-based hormonal? Is it thyroid? Is it adrenal? And what does that mean? If we say it's adrenal, but really adrenals aren't typically adrenal, they're more stress and brain. And so, and then is there infection? Is there constant inflammatory cascades? Is it gut related? So we kind of look at all those pictures. For a while, I'll digress for a second. We have a full-time psychologist on staff too, PhD in psychology. And for a while, all of our new patients had to meet with her for an hour. So she got too full to do that, but many of our patients still go through her because people with chronic illness, there's a psychological component. And as I say, if you've been sick for 10 years and there's not a psychological component, there's something wrong with your psychology. Like
that's right. What are you ignoring?
So it's become a crucial piece to just understanding. And so putting that is the short answer, or maybe the long answer to clinically, what are we looking at? What's driving your I don't feel good-itis, and not being biased towards a certain diagnosis?
Yeah, and that's so profound, because if you listen to all the marketing gurus that work with people in our domain, everything is about niche, right? Be the thyroid person in your geographic region. Pick something that you can be very specific and drill down on. And you and I tend to have the same thing. I've done a little bit of marketing. I actually do no marketing now. And I never found that niching down and trying to attract certain types of cases was effective clinically, and certainly wasn't fulfilling for me. And, I have a saying and I use this in Func Med seminars all the time. It's like, how do you work up a case? So you work up the case. Right. You work them up and you fix what you're finding. Well, doc, what do you do about XYZ? I'm like, well, you work them up and you fix what you find. And that's counter to all the messaging that's being put out there to people who are in practice and people who are trying to get into practice. And I think that maybe the savvy clinician / health entrepreneur would have that internal process. But as they face out towards the community, like, okay, I'm advertising for Hashimoto's, for example, I'm advertising to get Lyme. But once they walk through my door, you're in my world now. And we're looking at everything because we have to.
Well, I also think it's not good for our profession to say all Hashimoto's is treated one way. Like they have the Hashimoto's case fee, whatever, $8,000, and you do this, and this is what you're going to do. I think that's probably a disservice to the patient, the clinician, and our whole profession. But I do think there might be some wisdom in internally. I'm going to bite off thyroid for the next whatever. I'm going to bite off Lyme for the next whatever. So internally, you want to kind of sharpen your clinical saw and understand and drill down into what that means. And I often look back and say, maybe I'm the way that I am is because I took a year and drilled into Lyme. I took a year and drilled into, so autoimmunity, understanding the mechanisms behind it and understanding Lyme disease and understanding, water damaged buildings. And so maybe I've done it in silos, but I've never presented it as this is the type of clinician that I am.
Right.
Yeah.
Right. Yeah. And if you go, if somebody wants to go to my website, you'll see the same thing. I talk in general terms, and I might every once in a while on a certain web page talk about certain conditions just because they're so prevalent.
Right.
But it's not because I think of myself as the expert who has that thing figured out and I know the secret sauce, so to speak. And, I just love the idea of being well-versed in a multitude of different clinical problems. And I think that the only way to do that is to have a certain level of understanding of human physiology. also understanding that you don't know what you don't know. And the moment you think you do know everything, a case is going to come in to prove you wrong.
Correct. I was recently, so Richard Horowitz, who's one of the foremost Lyme doctors, I recently did a lecture with him together. We were at dinner. And if you ask him, and he's brilliant, not taking it, but he's figured out Lyme. He's absolutely, I've figured out Lyme. I've solved Lyme for the world type of a thing. And he's done some great advances in Lyme treatment, but we're in central Pennsylvania, we're Lyme central. And I don't think anybody's fully figured out Lyme. And I think some of the nuances are, you never come in with one condition, right? So you're not just Lyme. You're Lyme in a situation where your immune system was compromised enough that you can be pro-inflammatory, which now causes polyreactivity, which leads to autoimmunity, which leads your natural killer cells down. Now you're more susceptible to a water damaged building and you're not sleeping at night. So now your brain chemistry isn't. So you're never just a one condition. And if you only focus on one pillar, you're not supporting physiology. You're not, right. I use this again, humbly, a cardiologist's job is to not have you die from heart disease.
Yeah.
And they don't care if you die of Alzheimer's.
That's right.
So we're the opposite. We care about you as a human being, and we're here to support every piece of it.
Yeah.
So.
Yeah, no, I love the way that you put that. I would love at some point to have you on to talk about Lyme, because that's obviously a very broad and a very deep topic. I won't burden you with that right now. But, you and I, in many ways, have gone in opposite directions in terms of the business side of things. You have, without setting out with this strict intent, built the largest or one of the largest practices, Func Med practices in the US, and I would say therefore in the world. I've gone the opposite way into more of a boutique style, where I take very few clients every month and I do everything. I have zero staff.
Mm-hmm.
I have no staff.
I envy
you. Well, in many ways, I envy you, because I don't have that community and that camaraderie. If I have a challenging case, now I can text you, I can call you, I can talk to Sam or Datis or Ari Vijdani or anybody else who I think has the answer that I don't have. But it's not like I can walk, get up and walk 15 feet and knock on someone's door and say, hey, can you look at these labs? Here's the history. What do you think about this? I mean, I don't have that. So there are things about your world that I am envious about professionally. But like you said, there's probably things about this boutique style that I pursue that you would envy as well.
Oh, it's not. It never turns off for me. But to your point, we have a nephrologist on staff, right, who does functional medicine now. So if I have any kidney condition, and I'm okay, and I might put myself at like 10th grade when it comes to nephrology. She's like a double PhD. She was nephrology 40 years in the hospital. So I walk down the hallway. She could do in her sleep what I can't figure out. So there's some benefits to that.
Yeah.
But to your point, in another month, we're opening another office, and we're actually opening an Amish hospital. So it's going to be huge. So I have to go to every office at least once a month, and it's taxing. So when you say you do this, you get to focus 100% of your focus just on a few patients or clients that you're taking care of.
Yeah.
And there's some of that I do envy. I also love the fact that I got 20 clinicians, and sometimes I'm the escalation clause, like, hey, what do you think of this? What do you think of that? And it causes me to continually learn and see things. And one time I saw something, I'm like, oh, that's da-da-da-da-da-da. And she said, how did you know that? I said, because 13 years ago I saw that. But you're never going to learn that. There's just something about your apprenticeship, and it's the apprenticeship of life that doesn't end until you retire. That just brings it all to focus.
Well, that seems like a kind of a natural pivot point then to start bringing this to a close. And I do hope we can set up more time to talk, because there's so much to go through. But I have a series of questions that I've asked everyone that's been on the show so far, and that is, in the realm of advice. I mean, you're already in a mentorship relationship with the 20 odd docs that you have working in your practice. And there's so many more. I don't know at what rate functional medicine is growing, but there's so many more of us now than there were 10, 15 years ago. And I would imagine every 5 years that number is going to increase by some magnitude. And a lot of times they're coming out into practice or transitioning from an existing type of practice into functional medicine, and they're maybe lost, maybe confused. And one of my messages to anybody who's listening is that first and foremost, you have two guys right here having a conversation at two ends of the spectrum. You've got Chris Turnpaugh, the head honcho of the biggest Func Med clinic in the world, and you got little old Steve with a boutique practice, working by himself, doing all the diet coaching and everything by himself. And we're both very happy with what we do. So my message to a lot of docs, whether they're brand new or just transitioning, is listen, your practice can be whatever you want it to be, right? So what would Dr. Chris Turnpaugh say? I've got three different categories of people. One is someone who's just graduated from any type of licensed healthcare practice, and they're just getting into practice and they want to start doing Func Med. What advice do you have to give them as they get started in functional medicine?
Well, one of those is find a mentor, find somebody that you can talk to. So don't think you have it all figured out. Now that most people would say, go work for somebody for a period of time before you want to start your own business. I don't know that you need to have somebody that you can reach out to, who you trust, who's going to tell you what you don't know and also tell you what they don't know. Like somebody that you're a mentor says, I don't know what that is. I've never seen that before. I think that's super important. I think there are silos. So I've done all the A4M, all the IFM, all the ILADS stuff. I think those are really good, and they allow you to get a community so you can talk to people.
Yes.
My pushback on that is don't assume when somebody speaks in the front of the room with confidence that they're correct. So, and I mean that because we just took 18 providers out to A4M in Vegas, and they all went to these places. And you can always, the seasoned clinician can tell that's not 100% true, what they just said in the front of the room. So, because what it does is it breeds doubt. Why is the person in the front of the room fixing everything? And I suck. That's right. Keep in mind that they don't have it all figured out either. Now, you want to project confidence when you're teaching, but nobody gets up in the front of the room and say, let me show you a case I really screwed up. But I do. I go I'll get up and see this. This is how bad this one was screwed up. Oh, and by the way, I had a vested interest because it was my daughter or my wife or my, so you realize just nobody has it all figured out. So get a mentor, someone you trust that's humble enough to say they don't know everything.
Yeah.
And then I think it's important to get a community. So whether it's a functional medicine network or something like that, more of those are popping up. And then do what you're comfortable doing and know when to punt. It's okay to say, I worked this one up. I've helped a lot of people. I don't have the clinical, nobody wants to say this to themselves. I don't have the clinical competence to go to the next step. Who can I refer this one to and learn from it? Know when to say when, know when to know you don't know, right? Yeah. And as you do that, you'll become more and more comfortable and confident doing things. We benchmark ourselves against the leaders of the field, the people that have it all figured out, and they're brilliant people. I don't ever want to be that person that has it all figured out. I want to be somebody they can talk to. There are leaders in our field. We talk about the T's, brilliant, great. Realize it doesn't always work out the way that it's presented. Sure. And it's okay to be that way, and know when to say, yeah, this one I should probably refer out. And you don't have to refer it out to, you don't have to abandon functional medicine. There are other functional medicine providers that do things. There's functional medicine practitioners that specialize in cancer. But you don't want to fumble. You don't want to be me in 1996, right? And taking on a guy with ALS, thinking you have it all figured out, when there's a person's life on the other end of the line, especially in a community where people are helpful. Hey, let me help you with that. Let me work with you. So I would say, get a mentor or someone at least you can bounce ideas off of, get involved in a community, and then sharpen your saw every day and know when to punt is a big one. I'm not really sure what's going on. Nothing is going to breed respect when you send them to the hematologist oncologist, when you've worked them up better than most would have, and you don't know what to do. They're going to appreciate that. They might, it's going to be a little bit of a rough curve and have some thick skin too, because you're going to have to go through some rough patches where they think you're the weirdo. Yeah. But I will say over 25 years, and you can maybe speak this, it's less and less weird, right?
Yes.
So I just came back from the eye doctor. As I'm checking out, the two receptionists are asking me questions about my office. The whole office knows about us. Now we're big, but the whole office knows about us, and they're a standard eye doctor, right? So, but 20 years ago, they wouldn't have talked to me. I was the weirdo. I was the freak. So realize you want to bridge gaps. And if there is a problem, you're going to have to send them to those silos that have been around for a while. So you don't
want to burn your bridges. That's for sure.
Right.
Yeah. So what about the person who's in practice in some discipline, whether it's chiropractic, acupuncture, allopathic medicine, whatever? They have some years of history practicing and working with people under their belt, but now they want to start either doing integrative medicine and I kind of make some distinctions myself between integrative and functional medicine. Maybe I shouldn't, but I do. Right. But they want to get into that. Like so I've got some experience. I have a way of doing things. Now I'm getting into this whole brave new world called functional medicine. What do you tell that person?
I'll give you two different possibilities. One would be like chiropractor. Someone's coming in with, let's just say, you're a musculoskeletal guy, right? And or girl and or woman, and you're coming in, and they're coming in with this chronic pain, chronic inflammation. We actually we taught a course on a lot of those patients may have Lyme disease. Some of those patients may have thyroid conditions. A lot of those patients, and so you could say to the patient who's coming in an already established practice, you already have your breeding ground for functional medicine, because don't take it the wrong way, listeners. You probably have misdiagnosed a lot of these people, and they're right there, and you already have the trust. They're already coming to your office. They're trusting you. They're already there. And you could say, you know what? I'm going to try something a little different. Would you mind if I ran some labs on you? Just some simple labs. And you'll pick up the thyroid conditions, the Lyme disease, the chronic inflammation, the anemias, the simple things. And then you can start to sharpen your saw that way. Allopathically, I would say the same thing. You already have the trust. The patient's already coming in. Even more glaring, they're seeing patients that are not being treated to the best level of healthcare. They're already coming into your office. You can start to learn based on your pre-population that's already coming in, and you can start to transition and go that way. It's really hard people want to make the jump. Like, I'm sick of allopathic medicine. I'm going to do functional medicine and then make the jump. And everybody that I've talked to, I said, you don't want to forget all the wonderful knowledge that you've already brought in to the day, and you just want to slowly add to it and build on it. I don't know if that's right. That's what I've seen work, is like, hey, you're running, we'll pick on something, you're running a TSH. Have you ever run thyroid antibodies? And if you have thyroid antibodies, have you ever thought about diet or leaky gut? Are you running their hormone levels of T3 and T4? Do you know? I can't tell you how many people are running cholesterol panels and they're not running an ApoB or an LP(a). And I know those are probably detailed for some people, but like you're missing the number one killer in the country.
90% of the story, right?
Yeah. And you're missing the whole piece. And all you have to do is run an $8 test, and you can start running that on every patient, and you can learn along the way, because what you've done isn't horrible. So good isn't the enemy of perfect, right? So if you say, I'm doing a pretty good job, I want to do better. Well, better isn't the enemy of perfect either. So just try to do better every day, and don't let it be the enemy of, oh, I missed that thing, because that's all of us, right? Neither one of us would practice the way we did 5 years ago. So we're better, and neither one of us is perfect. Better is not the enemy of perfect. Let yourself get better in the practice that you're in.
Yeah. And again, to your point,
to those people, get a mentor, get involved in a community, reach out. I can't tell you the amount of, they're usually after hours and they don't want to admit it, but a lot of the allopathic doctors will call me and say, hey, what do you think of this? What do you think of that? We have a little hospital you might have heard of down the street from us called Johns Hopkins. And sometimes we fight with them and sometimes we agree with them, but we have to stand on strong clinical data points to be able to talk to them. And that opened the dialogue for them to talk back to us. Hey, what do you think of this? I don't know. And more often than not, they will say, we've done everything we can here at Hopkins. Go to Turnpaugh's place and see what they can do for you. And that's just a huge, I mean, what a huge change from 20 years ago in functional medicine, where they've run up the end of their flagpole. So listen, if Johns Hopkins can punt, then you and I should be able to punt.
Right? That's a very good point. Yeah, it's not just a one-way street there.
No.
That's amazing. You know, I think back just based on what you were saying, the first functional medicine seminar I went to was blood chemistry analysis. And it changed my life because it changed how I saw the world. And I remember driving back it was in Fort Lauderdale, and was over in Sarasota at the time. And I'd been in practice, doing chiropractic, musculoskeletal neurology work for, I think at that point, probably about 10 years. So I had some experience, right? I look at 10 years now as like, okay, I was just getting started, right?
Right.
But I remember that 4-hour drive home, thinking of all the patients that I had worked with under the chiropractic model that didn't get better, didn't get the results that we wanted. And I started to realize that they all had metabolic issues. And so, like you said, I started, because I was still doing chiropractic at the time, I started with the clients that I had a lot of equity with, that really kind of we knew each other by first names, we knew about our families. And so I could walk in, like you say, and say, hey, Mrs. Jones or Sarah, I've been thinking about your case. I think maybe why we're not getting better is because this is going on. Let's run some labs. So that's how I got started. Let me go to the last one and then I'll let you go, because I know you probably got a bunch of people clawing at you. Like, where is Chris? What about the person who's doing functional medicine, but they're struggling to make it work?
So I'll answer that in two different pieces. One of the other pieces that I find, because, I love Datis Karazian. I think he has taught me a tremendous amount, and he's changed the way that I practice. One of the benefits that I got to see from some of the other speakers was I was involved heavily in functional medicine before I ever met him. Right. So yes. There's not something wrong with it, but I was never a Datisite. Right. I was one of the dissenting views. Sometimes it's wrong, but I was one of the dissenting views sometimes. And so I think that when you follow a certain dogma of a certain leader, then you have blinders on to learning other pieces. And I would say this with the utmost respect, because if I was a Datis follower and everything that Datis said I took as the gospel, right? Which is not a bad way to go, by the way.
No, not at all.
But if you look at Datis doesn't have a single person that he follows, because he's wise enough to go to Harvard and get his degree and listen to other people and read the research. So instead of following a single person, that single person, if they're brilliant, like Datis is, he's not following any one person's advice, right? Now, it's great to have it funneled for us with somebody like Datis who can teach us. But when you just follow one person, and we've had these people in our profession where this person, everything they say is right, and everything that they don't say, everybody else is wrong. I think if you can get that breadth from other people and marry them together, that's going to be helpful. So back to all three of those camps is listen to a lot of people. Listen, if you said you got to hitch your wagon to Datis Karazian, you made a right choice. That's not a bad choice to do,
right? But
you got to realize his information is coming from such a vast knowledge. Allow yourself that breadth too, to learn from that vast knowledge too, right? Yeah. So, and I think that's gonna help, and you're gonna find how you resonate, what resonates with you, and what type of things you're gonna learn quicker, and what styles you're gonna learn quicker. The person who is struggling, so that's one of the things is, have you been following, Dr. X? Have you said, this is the person, I've followed everything they said, it doesn't work for me. Start to look at other places.
Look elsewhere, yeah.
The other thing is, this is me, and it probably will not resonate with everybody. I don't think, if we go back to, you had a patient population, they've already been trusted, and you said, hey, Mrs. Jones, let me run this thyroid test on you. I think I'm missing something. That's not the big, come in, let me market to you a case fee of, this is what we're going to do, and I'm going to have you fixed in 6 months. I think it's easier to drip it in. That's me personally. Like, it's easier to say, you know what? So I've never been a case fee person. It works for a lot of people. That's more the business side. But if you say to somebody, you're here we're going to add this one little piece, or I'm going to do this one little thing. What I say is I'm going to pivot from the current path that I'm on, just a little pivot instead of, okay, we're going to do this big chunk. It's easier to do in bite-sized chews, whether it's a chiro patient that you're running a thyroid panel on, or whether it's a patient in allopathic medicine that you're running antibodies on, or whatever that is. They're little steps, and get those little steps. So if you're struggling, I think most of the people that I see struggle, they're focused on the marketing, they're focused on the selling. And I can tell you from my experience, if you focus on just clinically getting better than you were yesterday, and you get better outcomes, there's a plethora of sick people, and they're getting sicker, and they're going to say, where did you go?
Yep.
I went to see Dr. Noseworthy. I mean, I'm sure that's how you get most of your patients now. Like, it's word of mouth. You're not really, you don't have a billboard out there. If you're struggling, look at your fee for service, your value, what you're doing, and are you getting the clinical results? Again, I'm the village idiot. What do I do when I teach? People would come up to me every time I lectured and say, what business coaching do you do? And I walk up to some gentleman in the front row, I put my hand on his shoulder, and I said, I care about you. That's my business model.
That's your business model, right? And I was going to say that as you were talking about, be a better clinician, like be committed to that every day, every year, being better than you were before. But, implicit in this entire conversation, it's very, very clear. I think anybody who spends more than 5 minutes in casual conversation with you will understand where you're coming from. And that is you deeply care about taking care of people who are suffering and doing what you can, knowing that you can't fix everybody, you won't fix everybody. And that's why you've assembled this amazing team around you to do the things that you can't or aren't good at. And I think that is, I'm just going to sound like I'm blowing smoke up your butt, but I mean, it's a sign of a humble leader to be able to let go, but still be there in a guiding capacity, and just to let other people, sit with you for 3 months and then kind of launch them out and stay there as a mentor. I think it's an amazing thing that you've done. I really, really do.
I'll say this again in my humbleness. I don't have it all figured out. It's a struggle for me on a day-to-day basis of, when do I have to overstep the bounds? When do I have to let them run? When do I have to learn? When do I have to teach? Those type of things. And to go back, I'll echo Dr. Shannon Smith, who's been with me for 7.5 years. Brilliant, but he came in to shadow, and kind heart, compassionate, a version of me that I couldn't even ask for of any better. So one of the things that he noticed was when I would do the interview and just developing that connection with the people. So often these management companies, they're get the right color walls, sit knee to knee with them, all that stuff to me. I'm like, I don't understand any of that. So I'm going to do a little thing. Ask me a question. Just ask me, like, I'll pretend I'm a patient. Ask me what my health concerns are. Just try that.
Oh, you're asking me?
Yeah, I'm actually asking you to go through this, because this will be pointed, because this is what I did with Shannon, and it hit him like a brick. So go ahead.
Yeah. So Chris, what brings you in? How can I help you?
Well, and I'll just stop there. That's an awkward, uncomfortable thing that most of the practitioners want to fill well, then they'll say, well, actually, just tell me how you're sleeping. Well, just tell me. And what we're doing is we're filling the void and talking to the patient. And what the patient wants to do is be heard. And that awkward silence. I've sat in this room, and it's really challenging with some Amish patients. I've sat in this room for 5 minutes in absolute silence.
Wow. Yeah.
You have to be vulnerable to me so that I can be effective with you.
Yeah.
And if I keep filling the void, I don't allow you to be vulnerable. And if you're vulnerable, then I can see, hopefully, the weaknesses where I can enter in and help heal. But if, as a clinician, we want to talk and tell people how smart we are and how we have it all figured out, and this is what I'm going to do for you, and this is how I'm going to get you better, as opposed to, I'm here to listen to you. You've
Yeah.
been struggling, you're hurting, you're sick. Tell me, and I'm going to give you the respect to listen.
Yeah.
I'm going to sit here in an awkward silence until many of the times tears will form in their eyes and they leave and they say, you're the first person who heard me.
Yeah.
But you're the first person that we allowed them to be heard.
Yeah.
I just think that's so overlooked. I know it's
No, it really is, because you're right. We, a lot of times, and I fall into this trap sometimes with new clients and initial consults, is you want to demonstrate your knowledge, but you're focused on the problem solving, understanding and solving the problem, and you put that in front of understanding the person, right? In fact, I just put a podcast out on my client facing side a week or so ago, talking about, it's important to not just have your doctor understand your symptoms, but your story. Like how's your fatigue and your brain fog and whatever, how is that affecting your quality of life and your relationships? And I would imagine that you've had the same experience. It's, you probably should have kept count over the years, but how many patients have broken down in tears because they feel validated? Like, just because you listened and you said, listen, this isn't in your head. I might not know what it is yet. I have some ideas, but here's what it looks like to try to figure this out. And I'm sure your experience is like mine. Like, a lot of people they'll just release, the tears come.
So, and to the clinician side, as you say, the tears come, the trust is built, the relationship is formed. I've already disclosed to them I'm going to make a mistake. I now have a little bit of a grace period because there's an emotional bond that's formed that I don't have it figured out. So they don't cut and run the first time I do something wrong, which is going to happen.
Yeah.
Because it's more important to say, we could talk for hours, but there's a story.
I'm looking at the clock going, it's almost an hour and a half already.
But there's a story about there's a guy in a hole, right? There's a guy in a hole and the government comes by and they throw money down the hole. They try to, I'm going to throw money at you. And then, the priest or the rabbi comes by and they're going to say a prayer for you and all this kind of stuff and all this stuff. And then guys like you and I walk by and we jump in the hole. And they say, what are you doing? You jumped in the hole. And you're like, I've been in this hole before. I'm going to walk with you arm in arm on the way out of this hole.
Yeah.
Get in the journey with them. It means something. I'm here with you. I'm not a doctor talking down to you. I'm on this journey with you. I'm on this journey with you, and I'm going to allow you to heal. And healing comes in every social, emotional, physical, chemical fashion. They have to have that bandwidth to do that. And they've never, listen, they've been sick for a period of time. They don't feel better. Nobody's listened to them. And just giving them that opportunity. I think that's, caring about them, and you're caring about them. If it's genuine, don't make it up. If it's not in your heart, don't be that person.
Yeah, no, don't be who you're not.
Don't fake it. But if you genuinely care about the outcome of the person, you're going to have a better opportunity to get them better. And that comes from allowing them to tell their story. And so often they're not allowed to tell their story because they have a 7-minute or half-hour visit with their allopathic doc, or they're in with a functional med doc who's had scripted sentences to tell them what to say, so they know that. And listen, open it up, be vulnerable yourself. To what I had a patient once, and he two scenarios. One I won't go into. It involved, the lady came in for her thyroid, right? And in the 59th minute, she had shared with me about how, and she was very heavy, very, very, very heavy woman. She shared with me about how she was repeatedly molested by her father since age 3. That comes from 59 minutes of caring and listening. She wasn't there because of her thyroid. And if I'd have stuck with her story and not listened to her and allowed her to be vulnerable, no way I was going to help her at all. That doesn't come from a 7-minute visit. That comes from moments of silence, moments of compassion and caring, and allowing them to share themselves with you. And that's where we're going to get people better.
And I mean, that particular example aside, do you have any problem sharing any of your own health struggles that you've overcome over the years, just to show that like, hey, I'm human too. Because, you know, if you look out in the world of the internet and marketing, you have the people who hold themselves up as the absolute pinnacle of health and wellness. They're in perfect shape. They're this, they're that. They've never struggled with anything. And all you have to do is follow me because I am the pinnacle. And then you have the other people who market on the sense of, and a lot of times these are niche marketing techniques. You know, I had a thyroid too, and I overcame it. Let me show you how to do it. And, you know, I think real people are kind of somewhere in between. Like, so I personally don't have a problem sharing that I have struggled with weight at times in my life, or with orthopedic issues in my life, or with blood sugar control. You know, I've got an insulin resistant phenotype. And so if I don't take care of myself, yeah, I'd be a pre-diabetic pretty quickly. Yeah. And I have no problem sharing that. It took me a while to get to the point where I didn't feel like I had to be the pinnacle of health in front of everybody, and I could be real and be human. But sometimes I think that opening up just a little bit with people gives them permission to start to open up to you at a deeper level than maybe you would accomplish if you didn't do that. Like, how do you handle that kind of stuff?
Well, I'll share my story if you have another 10 minutes. I mean,
dude, I've got another hour.
So my story, I'll give you the miniature long version. I was born in Germany on an Air Force base, had 9 consecutive pneumonias. While I was in the Air Force base with 9 pneumonias, I was in an oxygen tent. They didn't think I was going to make it. I was being vaccinated at the time. And instead of breast milk, which can cause congestion, I was fed red Kool-Aid.
Oh my gosh.
So that's where I started, right? So I started with red Kool-Aid injections and no breast milk, right? Finally, after the 9th round, my mother said, he's coming home with me. And the hospital said he'll die. And then my mother said, to her credit, then he's going to die at home with me. He's not dying here. So then anyway, I don't remember any of that, right? So
your mom.
Oh yeah, amazing. So I do okay, pretty healthy. Around 11 or 12, I get pneumonia again, and I develop asthma. So then I have this asthma condition. My immunologist or pulmonary therapist said, you're going to have emphysema by the time you're 40. It's really bad. But in college, I changed my diet and things changed. So I get a little bit better. Fast forward a few years, that was all background to probably prime the pump for what I'm going to tell you next. So then I started getting burning pain all over my body in my 30s. And I started to develop a little bit of a foot drop on my right foot. And if I would run a little bit, it would go complete foot drop. I couldn't pick my foot up at all. And so I'm like, and I had this pain where I felt like thousands of bees were stinging me if it got above 72 degrees. So the heat was just tremendous. So, and I started having some cognitive issues. I went to all kinds of doctors. I finally went to that little known hospital, Johns Hopkins, did an MRI, 13 lesions on my brain, including my pituitary gland. And they said, you have MS, and now we want you to go on beta seron and inject this stuff into your body once a week. You'll feel like you have the flu for 3.5 days, and then you'll feel normal for 3.5 days, and then it will hopefully prevent the progression. And that's where I drew the line in the sand. I'm like, I don't know much, but I ain't doing that. Like, I am not doing that.
Have you heard of CoQ10?
Yeah. And here I am in this profession. This is 2003 that this happened. Prior to that, I'm holistic minded, but I went on 13 different prescription medications because I thought none of them worked. So they weren't long term. None of them worked. I felt horrible. Like I was losing myself and my sense of self. So finally I figured out, okay, it's that. I went to one of these docs. My vitamin D was really low. My testosterone was all but 0, right? My testosterone was low. My LH and FSH were all but 0. So I had no pituitary function. Coming out. So then they said, you'll never be they give you the whole accolades. My house is built handicap accessible with a first floor handicap bathroom for my wheelchair. Right. Wow. That was in 2004. We built the house. I was told there's a 50% chance you'll be in a wheelchair within 5 years and 100% chance within 10. And that was in 2003. Right.
Amen.
So they were like, it's just not, you have primary progressive multiple sclerosis. You're done. So much like you were saying, I didn't share with anybody. I was afraid, a lot of fear. I thought they were going to take my license, my way of life. How am I going to support my family? What am I going to do? I'm going to become a burden. I didn't tell anybody. I didn't tell my closest friends. Then I started.
There's like a level of shame, right? Because
There's
you're
a
like,
ton of shame. Like,
I'm supposed to be the healthy person.
Yes, I'm the guy that does it right, and I should be healthy. And again, I didn't know in 2003 it wasn't gluten free. Didn't know anything about that. So fast forward, changed a lot of my life. Learning curve goes up a lot. Tried a lot of stuff holistically. Some of it I'm sure didn't work. My wife got Lyme disease. She started losing her faculties from the neck down, but she quickly recovered. Like, she was better in weeks. I did the whole Lyme treatment with her because there's in the Lyme community that say MS is Lyme disease. That didn't make a difference, but I did all that. I did the whole Lyme treatment. So, and then I started to slowly get better over time. 2009, I had a follow-up MRI, and the static lesions, which don't go away, were all gone. There's no lesions left in my brain. So, but they say, they weren't active puncti foci flares. They were actually lesions, which are scar tissue. So they won't go away. Well, they're gone.
Yeah.
So
they're gone. Yeah.
Yeah. So, and I run my labs every month. I told you that. I live on
That's
the
why I
edge.
was wondering if this is why, right?
Yeah,
You're just
I live on the
surveillance
edge of
mode.
when is it going to come back? My brother, who's my biggest advocate, he says, it's coming back because it never goes away. He's not being mean. He's just speaking what he thinks is out there. So, we did this little interview. I haven't missed a day of my supplement regime in 15 years. I have never missed a dose of what I think is important to me that day. So it's changed over 15 years, but I've never said I'm going to take today off. I've never missed a day. And so my story is, yes, am I better? I've done a couple adventure challenges. I this past October, I climbed the Grand Tetons. These are things that you're not supposed to be able to do. Now, am I 100% better? There's days I still get some burning, some tingling, what most people call a little bit mast cell activation. There's probably environmental things that aren't perfect in my world. But by and large, if you ask me, I'm better. I'm 100% better. But I don't wear that. I'm starting to. So I was talking to Jeffrey Bland about it before our podcast, and he says, you got to tell the world that story. But for so many years, I was ashamed to tell it.
Yes.
And then I also didn't want to be the person you said, like, come to me because I've had MS and I got it better.
That's
because I've had patients with MS who have miraculously gotten better with what we've done for them. And I've had MS patients who didn't get better with what we've done for them. So
that makes me think of Terry Walls and the work that she's done. And I know people who have followed her protocols and done very well, but I've also personally seen patients who followed her protocol and didn't get it.
Terry Walls was at A4M where we were. And I was a little bit angry. I had a chip on my shoulder. So I didn't like the fact that Terry Walls became famous for her condition and got better. That was a me issue, right?
Yeah.
And I've slowly gotten over that. Like, look at the amount of people that she could potentially help. So my wife runs into Terry Walls walking at A4M and couldn't be a kinder person. Gets a picture with my wife and says, I'm so grateful your husband went through that. Have him share his story. So it was a between my ears issue. I just didn't want to be the person that said, come to see me because I have had this condition and I can get you better as well. So it's been you talk about the emotional struggle. It's been an internal emotional struggle. So, and recently I've been more vocal about it. So I said it to Jeffrey Bland. He's like, my God, look at the amount of people that don't know there's an option because they've never heard your story. So maybe they should hear your story just to know that even if you don't get them better, there's hope in other ways. So.
Well, when I was, before I became a chiropractor, I had a business and marketing degree. I worked for an ad agency in Toronto for a couple of years. And I had a chiropractor who was actually a student intern at the college, CMCC in Toronto, changed my life to the point where I thought, if I go back to school and I help one person the way that person helped me, it would be worth abandoning my career moving to a different country, going to school for 4 years, and then launching into practice if I help one person. And I'm so grateful that I get to do that on a routine basis. And I would encourage you share your story, because you'll help more than just one person realize that there is hope out there. There are some options. And I want to say one more thing, and we should probably really bring this to a close and then schedule another one. But, you were talking about your supplement regimen and how you haven't missed a day in X number of years. And you said, of the things that I think are important for me, because my first reaction, and I know everyone listening to this, is, what is Chris taking? I want that list.
Right.
But that list might not help somebody.
Right.
Because you think you developed that list probably over many years of diagnostics and perhaps some trial and error, and you discovered what works for you.
That's exactly right. And that's a beautiful take home. I'm glad you brought up. It's what I think is right for me, which I didn't say what is right for me. It's what I think is right for me, because I don't have it all figured out, as I've said. But some of that is diagnostic. I am absolutely crazy about running my labs. Like,
Yes.
I said that, and I don't recommend that to anybody. This is a choice that I'm making, that I want to maximize what I can see and help figure it out. Two is some of that is trial and error. Hey, this has been helpful. And the third is, what worked for me 15 years ago isn't the same that worked for me 14 years ago, which isn't the same thing I'm doing today. It is an evolving, changing, adapting as my body evolves and changes. I do some things differently. There's a couple things that are pretty obvious, like what's your vitamin D, how much are you taking, what level are you getting to? But even that, 15 years ago, I wasn't putting vitamin K with it, so I might have been advancing cardiovascular disease. So, like, there's learning pieces that go with it. So, but yes, what I think is right for me, and I have patients who come in, because I have routinely shared my story with a patient who comes in with multiple sclerosis, because I want them to know, I've been in this hole. I've been in this hole. We're going to walk out of this hole together. And they say, well, just tell me what you did. And I said, that's not how it works. It's not, your shoe size is not the same as my shoe size.
That's right. I love that analogy. I'm going to steal that from you.
Go ahead. Yeah. And so, listen, I wear a size 12.5. You might need a size 10, but if you find the right shoe, you're going to be comfortable. So just because I did something, now maybe a shoe is what you need. You might need something, but we got to figure out the nuance to that.
Yeah.
And so it's a passion that I have, and I'm going to, I'm going to go down swinging, trying to figure this out and continue to refine it. And my brother, who I love to death, I said he's my number one advocate, but he says, you're probably going to die before me. I said, maybe, but not for lack of effort.
That's
not
right.
for lack of effort.
Not for lack of trying.
Yeah.
Yeah. Well, cool. All right. Let's just end it there, because like you said, I think we can go on for hours and hours and hours. There is much to talk about. Dr. Chris Turnpaugh, thanks for being here. I hope I can get you back and we can talk about some other stuff for a long period of time.
I'd love to come back. I love it. So
all right,
thank you for doing this.
It's good to see you. Thank you.
All right.
All right. Take care.